Good evening, friends, and a warm welcome to this episode of 4D, which is Detailed Discussion and Dialogue in Indian Diabetes. 4D, it's our season 3 going on, and we still have so much more to learn, so much more to share with each other. We actually feel that as we talk more and more about metabolic disease, our horizons, our thought process, that keeps on expanding. So today, let's go to the fringes, let's expand our horizons, our thought process. We'll talk about metabolic health, targets, and techniques. And for this, we need some top edge specialists. So, a warm welcome, first of all, to Dr. Nirmal Shah. Dr. Nirmal is interventional cardiologist at Cardinova Healthcare in Narayanpura, Ahmedabad. Warm welcome, sir. We'd also like to welcome Dr. Manoj Kumar Agarwal. Dr. Manoj is an endocrinologist at ATOP Endocrine and Diabetes Center in Ahmedabad. Warm welcome, Dr. Manoj.
Hello, sir. Thank you very much for inviting me. And it is always a pleasure to be with you and in the same stage. So thank you very much. Yeah.
Thank you. We look forward to learning from you. And we also have with us Dr. Umesh Godani, who is a nephrologist. He's a specialist in both the left and right kidney, and he works at Kidney Cure Clinic in Hyderabad. Warm welcome, Dr. Umesh.
Thank you, sir. Thank you.
It's great having everyone on board. Dr. Nirmal, perhaps if you could unmute and then see. Dr. Manoj, let's begin with you. Our topic for today is metabolic health, targets, and techniques. Now, if we want a target, we first of all we have to know what we are aiming for, why we are aiming for. So, in your practice, what does metabolic health mean to different patients? Does the definition of health vary from person to person?
Yeah. So thank you very much, sir, for such a nice question. I think the answer would come from bottom of my heart. So now, fortunately and unfortunately, we are talking about the metabolic health and target. If we are talking about the era before 1960, then majority of every Indian were metabolically healthy. But after that, something happened like in such way that now we have to talk about metabolic health. So just I was thinking about today's my OPD, first patient and last patient. Between all the patients who came to my OPD, they do have a diabetes, hypertension, and every metabolic issue. But patient, and we think that whenever they have a diagnosis with the diabetes and hypertension or any metabolic issue, that time that journey starts. But I think from my perspective, that journey started 10 years ago. So it was not that snapshot, but it is a longitudinal movie that has been happened due to the bad lifestyle, ultra processed junk food, and the bad circadian rhythm. So I think as an endocrinologist, you are also the better persons to talk about that. If we combine the endocrine issues, then it is a lifestyle, rather than the organic dysfunction. So I think the modern era is like working and it is working against the metabolic health. So this is my perspective for the metabolic health and donation.
Thank you, Dr. Manoj, for putting that in perspective. We are trying to explore what our targets are for metabolic health. And Dr. Manoj has pointed out that our lifestyle, our environment has changed to such a great extent that now we find metabolism, simple physiology, so difficult to achieve. And we need to work on this. And we also realize that the patient may feel it is a snapshot or a cross-sectional disease that they have, but actually it is coming from the past. It is a longitudinal or a long-term kind of a game. We counsel different patients in different ways. For someone who is fond of reading, you might say the infinite game. For someone who is fond of religion or spirituality, you might want to talk about Indic philosophy, which says that there are these chakras of time. So what you did yesterday will impact you today. Your karma yesterday will impact your karma today, and that will impact your karma tomorrow. But in Haryana, where I work, the simplest analogy that we have is, so what they say is कि दीमक का तुरंत नहीं पता चलता. This is a very negative thing. So दीमक का धीरे धीरे पता चलता है, बट यू कैन कन्वर्ट दैट इनटू अ पॉजिटिव स्पिन, एंड व्हाट वी वुड से इन हरियाणा इज के बड़े के कहेगा और आंवले के खाएगा बाद में पता चलता है, which means that if an elder person shares some wisdom with you, or if you eat Indian gooseberry that is rich in vitamin C, rich in antioxidants, that the benefits you will get to know later on only. And this helps you motivate your patients to take therapy for long-term pleiotropic benefits. Dr. Umesh, how does it work out in the nephrology clinic? What does the word, the phrase metabolic health mean to you? And what does it mean to your patients?
Yes, sir. We are also facing the same with the pandemic of obesity and coronary artery disease. The CKD has now also become a part of metabolic syndrome. We can say that because majority of our patients are also like having obesity, diabetes, hypertension, and proteinuria. So CKD is also like that, as Dr. Manoj already said. It's not that frame, but it is the early root. So I think I always advise my patients, relative particularly, you start screening early. As early as from the 30, I advise them to start screening from the metabolic disease, A1C, lipid profiles, proteinuria, and creatinine should be checked early. So definitely now CKD is also a very integral part, and majority of the diabetes patients, particularly type 2 diabetes and metabolic syndrome patients, are developing, as high as 60 to 70% patients are developing diabetic nephropathy. And unfortunately, majority have come to us very late. Many just come to us near to start of dialysis or in the stage of macroproteinuria. Even majority don't know even they have kidney disease. So I think you guys, endocrinologists or physicians particularly, because endocrinologists are always aggressive like us. But I've seen that many times the treating physicians, they consider a patient having a CKD only when their creatinine is more than 2 or more than 3. That is actually very high. If we come to the stage of CKD, it's already CKD stage 4. So that is also a problem with us. At that stage, we have limited options because majority of our saver molecules like SGLT2 or MRS, they are approved for GFR more than 30. But majority of patients are coming us with polytherapy with so many complications that many times we are actually stopping the drugs because of either hyperkalemia or UTI. We are stopping SGLT two inhibitors. So that is a problem, but definitely it's always early diagnosis and early screening to deal with this pandemic, I can say.
Thank you, Dr. Godani, for sharing this. And you're right, metabolic health is something we should aim for. And apart from that, timely restitution of metabolic health. We need to be timely, we need to be early, and we need to be aggressive. Dr. Nirmal Shah is also with us. From a cardiology perspective, Dr. Nirmal, what does the word metabolic health mean?
As everyone knows that metabolic syndrome or metabolic profile is an epidemic right now. What we are seeing is a tip of iceberg. Right? Many time patients with dyslipidemia, diabetes, hypertension, central obesity, visceral fat, high BMI, they usually present with complaint of dyspnea on exertion sometimes. Many time we just give, I have seen people giving just vitamins and all that, probably considering it is not related to any other heart issues because majority time ECG and echo would be normal. But if you go for the biomarkers or if you go detailing in the echo, you can see the diastolic dysfunction or stress related factors. Like you see the high BNP levels, you can see the LVH in echo, you can see the LS strain pattern. This all features indirectly is a suggestive of heart failure with preserved ejection fraction. So early intervention in this case leads to better exercise tolerance, overall better cardiovascular risk profile, and better it decreases the chances of future cardiac events. Right. Recently, I was just going through one of the article with heart failure with preserved suffering from subclinical hypertension, heart failure with preserved ejection fraction. So majority times we don't do a detailed investigation till the ECG and echo findings are normal. So my personal experience is every diabetic dyslipidemia, long-term diabetic, dyslipidemic, and hypertensive patient, specifically those who have the high central obesity or high BMI, should undergo proper evaluation as far as the cardiac symptoms or cardiac profile is concerned. Even though ECG and echoes are normal, we should go for the biomarkers, we should go for the inflammatory markers, and we should also have a detailed look at the echo findings. If these findings are suggestive of any strain pattern, we should optimize their medical management. SGLT2 inhibitors, RAS modifying agents, as well as low dose diuretics depends on the symptom, as well as the beta blockers. So these all medicines collectively, which have shown equally better outcomes as far as the heart failure with preserved ejection fraction is concerned, along with the aggressive sugar control. So, in my experience, I would definitely any patient with risk factors is complaining of breathlessness, then I would like to go for proper investigation in spite of having normal ECG and echo findings. Overall.
Thank you, Dr. Nirmal, and that makes sense. So suddenly our definition of metabolic health has expanded. We were thinking in terms of numbers only, the numbers that you see in biochemistry. But now what Dr. Shah has added, look at the imaging numbers as well. And echo is much more than just an ejection fraction. There are so many things that can help you pick up metabolic dysfunction quickly, rapidly. And like Dr. Umesh said, sometimes patient comes to us very late. You need a motivating factor, both for the physician and for the person living with disease. And when the echocardiography technologist or doctor is able to show those numbers, देखो आपका E strain pattern ऐसा है, वैसा है, this is your ejection fraction, this is your fractional shortening, that also might work as a motivational tool to seek early treatment. One thing we should be aware of is that in asymptomatic people with type 2 diabetes, NT-proBNP is now recommended as an annual screening tool. And if the number is more than 125, that means person is at high risk of CVD. So we need to be more aggressive. All the pillars of preventive, promotive therapy must be acknowledged. But Dr. Manoj, let's come back to the definition of metabolic health. So the definition of health has not changed for the past so many decades. As WHO said and continues to say that it is a state of not only physical well-being, but also emotional, social, mental well-being. Let us dissect this definition one by one. Now, you and I, Dr. Umesh, we wear spectacles. That means we are physically unhealthy, isn't it? So, where do we fit into the definition of health? All three of us. Are we healthy because we wear spectacles, or are we unhealthy because we have to wear spectacles?
The difficult question you have asked. I think the answer would be yes and no, both. So probably 70-80% it would be yes. That if you are talking to doctors like us, then it is a very nice research from the MP Shah Medical College where I have done my UG and PG. So in the Gujarat, 55% doctors has a type 2 diabetes. They do have hypertension. So here I think prescriptions writer who is writing the prescriptions for others, they are forgetting to write prescriptions for themselves. So the metabolic health issue in the doctors and affluent people are increasing. So that is why the metabolic health definition is changing right now. So previously, when we were into the MBBS or we were into our undergraduate, that time we have taught that obesity and overweight cutoff was 25 and 30. But right now, that cutoff has been shifted to 23 and 27. So that means we are becoming unhealthy. At the lower weight, we are developing diabetic complications. So I think this is very alarming for all of us that we have to change our schedule. I don't know by wearing the specs are we healthy or unhealthy, but the data shows that affluent Indians have a 60% obesity chance. And one nice research paper has been published by you only, Sanjay Kalra sir, that in Ahmedabad declarations. It was a very nice research in that it was talked about how Gujarati people are living. So in that, it was Gujarat is becoming second highest diabetic state, and that is why all the definition is changing. we are taking the cutoff of like HbA1c is more than 5.7, then it is a diabetic. Fasting is more, then it is diabetic. But our brain doesn't know this criteria. So if you see the functional MRI of the pre-diabetic patients, then they are affected. So we are just talking about the cutoff, but the journey has been started before. So I think the answer would be 80% yes, that we are becoming unhealthy, and now the metabolic definition has to change from one parameter to the second parameter.
If we just focus on this, Dr. Umesh, so this would be a perspective when we speak with our patients. Patient says, "Sir, my kidneys have spoiled. Now I am unhealthy." The WHO definition tells me that I am not healthy anymore because my EGFR has gone down, or maybe my albuminuria has increased. But then we can take this analogy and we can say, yeah, but the same way I wear spectacles, that is like a visual supplementation therapy. I can also give you a renal supplementation, a renal protection, or maybe if required, a renal replacement therapy. Poor health, ill health, is if you do not take the therapy, then you are not well. But if you take the best possible therapy from the specialist, from the nephrologist, from the cardiologist, whatever is required, then you will be healthy. So we can change the definition to say a state of optimized physical, social, emotional well-being. But even optimized may not be the right word. So let us take examples first from nephrology and then from cardiology. So here in our part of the country, we have got a million types of treatment for chronic kidney disease stage 5. So patients go everywhere. Sometimes they do protein restriction. Sometimes they take bath in hot water baths. Sometimes they take alternative care. They feel happy for 4 or 5 days. They say, I am optimized. But the full definition should be a state of optimal, sustainable healthcare. So how do you talk to your patient? Someone who has come with CKD stage 4 or 5 is very depressed, is unhappy from all points of view, social, physical, mental, emotional. How do you tell them that, yes, there is a way forward?
Yes. So I think nephrology is a counseling branch. So majority of the patients, what I have to do, rather than though we prescribe lot of different medicines, but actually very few drugs are there to prevent the progression of CKD. Though from the day one it was only the RAS inhibitors, then SGLT come, DAPA has so much evidence, but these are still for very early stage. So whenever a patient with stage 4 and stage 5 comes, my first and most important priority will be blood pressure control. So at very advanced stage, whether we are giving SGLT2 or MRA or not, but if he is not BP is not well controlled, I have seen many patients. They are taking SGLT2, they are taking ARB, but still their blood pressure of 160s or 170 are very poorly controlled. So then definitely they are not going to benefit much. So my first priority will be blood pressure control. I always definitely the patients they don't like the word dialysis. So with my first consultation, I never explain them directly regarding RRT. What I explain them, I explain them 3 types of treatment. And my first 2 most important parts are if they have diabetes, then diabetes control and the blood pressure control, the 2 most important thing. And then other supportive therapies. And most important is the dietary counseling. Actually, no diet is harmful to the kidney. I tell them, actually, I am making my job easy, so you require less drug. So dietary precautions are just to help the treatment, and no diet is going to harm your kidneys. For example, as you asked regarding the protein intake, so majority of patients they stop protein intake. So actually, in Gujarat, majority of the Gujarati people are vegetarian, and even if they are taking meat, they are take very occasionally. So their actual protein intake, which is recommended in CKD, is 0.8 gram per kg per day. But majority of vegetarian patients are taking even less than this. Even if they are not having CKD, their protein intake is less. So generally, I ask them to continue the pulses and whatever vegetarian protein intake they are taking. I ask them to avoid just protein supplements. So most important myth is to stop the pulses at all, because malnutrition is more harmful in CKD patients, particularly advanced CKD patients. In CKD5 and dialysis, CKD5D, we have so many data that even obese patients do well on dialysis rather than the malnourished patient, because mortality rate is very high. And if we look at the survival on dialysis, it's very poor. The average survival in India, if we look at the Indian data, it is many times it is less than 5 years. So which can be, I can say it is worse than cancer, many majority of the malignancy nowadays. So definitely malnutrition is more harmful. So I focus on that part as well. And salt and sugar are two poisons, I always tell them. So as much as you can restrict this, and based on their volume status, I focus on volume restriction. So majority of patients get relieved after dietary counseling, and when unnecessary restrictions are waived off, they become slightly relieved because it becomes easy. Then over a second or third consultation, I explained that in future, my first target will be to delay the dialysis because they are coming in a late stage of CKD, or to bring them down. Like if he is on stage 4, then I will try to slow down the progression, or bring him to stage 3 CKD, or to improve the EGFR, because many times there are few reversible factors. Many of patients have acute components like their ongoing UTIs, their ongoing nephrotoxic drugs. So the job of nephrologist is mainly to find the acute insults. So I need to give them time, and I need to find out the acute factors. So that is the most important. Otherwise, as a nephrologist, very few things we can do, because majority of patients are very late to us, and very few things like we majority of nephrologists are using keto analogs, but actually very rare, very less evidence for keto analogs in CKD progression retardation. But yes, we don't have much options, so we give them. But because of cost, we are not able to give them in a proper dosages. It is also a problem. So on the contrary, I more focus on finding the acute components. Many times, like the combination of these renoprotective drugs can also be impairing GFR. Like if we give ARB, SGLT2 simultaneously with high dose of diuretics, then also they can lead to AKI and worsen the CKD progression. So each patient has to be finely titrated by coordination of nephrologists, endocrinologists, and cardiologists. Like many patients I have seen, they are developing very bad pyelonephritis or emphysematous pyelonephritis after dapagliflozin. So whenever we start SGLT2, it is always important to see a past history of UTI. Does they have any urological issue? Does they have any prostate issue? Does they have renal stone disease? So basic ultrasound prostate workup is also very important before starting SGLT2, because many times in such high risk patient, it can lead to very severe UTI as well. Though studies say that it leads to lower UTI, but we as a nephrologist, we have seen many AKIs. So each patient needs individualized renoprotective therapy, and with slowly upgradation, not bombarding everything simultaneously, but sequential therapy. And for one patient, one may be better, but another may not be better. For example, a patient with diabetes, but his blood pressure are barely around 110 or very well controlled. If I optimize ARB very high, then he will develop postural hypertension or AKI. So here I will definitely prefer SGLT2 or MRI. If patient is having a many of diabetics having a hyperkalemia even without ARB. So the type 4 RT is also very common in diabetics. So many times hyperkalemia is also a problem. So then my choice will shift to SGLT2 first, and then I will try if I am able to manage the potassium levels with either sodium bicarbonate or with diuretics. Then I will add ARB or MRIs. So we have to individualize the therapy based on their parameters, based on other factors. Like if patient is very obese, then I may prefer even a GLP-1 agonist before GLP-2 inhibitors, because so with weight loss there will be significant improvement in blood pressure, sugar, as well as protein area. So I think now I approach them, and with proper counseling and finding the acute factors, majority of patients they believe, and they get a hope that they can even partially reverse, and in future they have option of RRTs.
The point well taken. And what we see is that our spectrum of metabolic health is increasing. Even though we say we are not able to do too much in advanced kidney disease, still there is a lot that we can do. Keto analogs are being used. Actually, perhaps how it started was because of the TINA phenomenon. TINA, there is no alternative. And that is why perhaps people began prescribing this, hoping to get some benefit. But now we do have benefit alternatives. We have got SGLT2 inhibitors, we have got MRAs like Finrenone, and these should be used in a timely manner. We also understand that there can be iatrogenic side effects, for example, hyperkalemia, and they have to be managed. So we see that the concept of metabolic health is expanding. One other thing I liked, or I would like to take back from what Dr. Umesh said, is that what is the point of talking about RRT on visit one? What is the point? So look at these three things. If the duration of your relationship with the patient is robust, it is long. If the degree of your relationship with the patient, their family, their community, their ethnic group is strong, then you can talk about RRT on visit one. If the level of distress is high, patient has got potassium of 7.5, obviously you have to suggest an immediate emergency dialysis. There is no other thing you can do.
Yes.
Then you will talk immediately. But supposing you have not built a good relationship with the patient, they have come to you for the first time. Creatinine is 4.2, I agree, but it has been 4.2 for the last 1 year. It didn't come about yesterday. Potassium is maybe 4.9. So then a good way would be to say, let's look at the positive points. See, the potassium is not 6.0. You are walking on two legs. You are fine. You are eating well. You are drinking well. So let's do all these things. Let's get a hepatitis B vaccine. Let's do the other thing. And you talk about the fistula tomorrow. Don't talk about it today. So three things. If the degree and duration of your relationship with the patient and family is robust, then you will speak about RRT or whatever intervention you have to do immediately. If the the level of distress is high, then obviously you have to treat. Let us talk about this from a cardiac perspective. Dr. Nirmal, two things coming to my mind. We go to the cardiologist and cardiologist says, "Aapko to ji heart failure ho gaya." When somebody says heart attack, that is an acute, correctable, manageable kind of a feeling. Heart failure suddenly makes you feel as if life has failed now, the end has come. So, how do you handle in cardiology? And it is especially so difficult. Patient has come with unstable angina. You are worried that the patient may, not survive for even half an hour. But patient says the doctor is just trying to mint money by advising an angiography and angioplasty. So, how do you handle this? It is such a difficult tightrope to handle.
Sir, in cardiology, what usually happens if some patient presents with a major heart attack, when he can see the fear of death in his face, like that kind of chest pain he's having, at that point of time, usually we clear cut explain the relatives that this is a do or die situation. This is the only thing we can offer him right now. Every single minute we are losing so much of myocytes. Right. So we
Yeah.
just make them understand that this is the severity of that condition. In usually that sort of time, relatives and patient himself, they usually get agree for any intervention, because the patient is in so much of chest, so much of pain. He is not even like we what we call in our language, patient will be tossing around in the bed. So he will say, sir, do whatever you want, just make me free from this chest pain. So that in those kind of scenario, in acute major myocardial infarction, there is no alternative rather than going for the emergency angiography and putting a stent. We have seen hundreds of patients just after angioplasty. Patient would be completely fine, asymptomatic, lying on the post ICU care bed, having a juice, and he will be like nothing has happened. So that kind of change you can see just within half an hour of your procedure. So that gives the even relatives and patient will be confident enough for the treatment first thing. So this is the scenario when there is any major myocardial infarction where you don't have any other option rather than going for emergency angiography and angioplasty. Second case scenario is when the patient comes with the stable angina with just a symptom of breathlessness. ECG is normal. There is no acute any major cardiac event as far as the ECG and echo is concerned. If you get a basic biomarkers in our field, it is troponin and NT-proBNP. If troponin is normal, basic cardiogram and ECG is normal, but BNP is slightly on a higher side. Now patient is complaining of the breathlessness, but not the typical chest pain. So many a times heart failure patient presents like this in early stage, providing the metabolic health of the patient. Patient is long-term diabetic, dyslipidemic, uncontrolled hypertension, so much of stress, sleep issues, all this leads to some chronic inflammation, endothelial dysfunction, leading to heart failure with preserved ejection fraction. In my practice, this is even a more danger than the acute MI, because many a times patients just ignore the symptoms. Probably they feel like I'm just getting weakness, or I am having some vitamin low in vitamins. Many a time I have seen the patient just taking vitamin B12 and D3 for longer period of time, and still their symptoms doesn't go away. And when we investigate this patient, it ultimately turns out to be heart failure, in with preserved ejection fraction. So in this sort of patient, we make them understand that it's not just a one or two factors which needs to be corrected. Your BP should be under control, your lipid profile has to be optimized, your sugar should be very much in control, and your stress level and sleep management also has a major role in the metabolic profile of the patient. So if all these correctable factors, if we keep check on that with the medicine, as far as along with the lifestyle modification, then patient symptoms get improved. Cardiac symptoms we have seen improving drastically just after having a modification on lifestyle, as well as with the help of the some medicines, which we say is the SGLT2 inhibitors, ARBs, or ACE inhibitors. If patients BNP are on slightly higher side, if they are not so much in congestion, so we just still offer them the ARBs, low dose diuretics, beta blockers, and SGLT2 inhibitors, and they have shown dramatic results. Patient will have symptomatic improvement within 3 or 4 weeks of the treatment. So we'll just keep checking their other metabolic profile as well as the symptoms, cardiac symptoms part. And usually they respond very well to the treatment.
Thanks. Dr. Manoj, so many magical M's coming out now. We are talking today about metabolic targets and techniques. And see what Dr. Nirmal has shared with us. First of all, you need modern medication. That is fine. And you can promise your patient that the results are good. In case you need an intervention, you tell the patient why the intervention is required. But you have to explain in Gujarati, in Hindi, in Malayalam. You should be able to explain to the patient why an immediate procedure is required. But apart from this, he talked about stress management. He talked about lifestyle modification. So, to modern medication now, let us add movement, that is exercise or physical activity, and meal planning, which is medical nutrition therapy. All these will be possible, modern medication, meal planning, and movement, if we are able to do mind management, if you are able to change the mood of the patient, how they approach us, what their attitudes are towards us. And both Dr. Umesh and Dr. Nirmal have spoken about the fifth M, which is monitoring. You have to keep on monitoring so that you can have timely decisions. So let's talk about mind management, which is the crux of all this. When we speak of health, we speak of the biopsychosocial model of health. We are all very good at advising the insulins and advising the SGLT2 inhibitors and renal replacement therapy. But what about psychosocial management of the patient? Any thoughts that come to your mind? Maybe any mistake that you made, you burnt your fingers in the last few months with
Yes.
psychosocial?
Yeah. So I think it is a very real life questions that you have asked about the psychosocial management. As a physicians, like we are trained to give medications like SGLT2 inhibitors for the hypertension, for the diabetes, for saving heart and kidney, both perspective, GLP-1 analogs for reduce the weight and reduce the inflammation. But I think the same focus should be given for the psychosocial management. I can share the real life case scenario. When I was in UK, that time it was a mandatory if patient has a obesity and the diabetes. That time he has to go to the psychologist to understand the reason behind the obesity. So just we think that metabolic syndrome is coming just as a number, but I think the number is not enough. The mind behind that disease is always there. So it could be the disturbed mind, it could be the disturbed sleep, or it could be the disturbed nutrition. As you rightly told, that 3M, mood, meal, and mind. So all is working in the synchronized manner, and we have seen that cardio, metabolic, and renal trial. So every system is very, very, very linked. So what we can do? First, we ask our patients to, after coming into the confidence, we have to ask our patients to take a proper nutrition. Now we have to talk about our dal roti, that is the originate of our food, not a pizza and pasta, because pizza and pasta is changing the mood, because it is creating the all-time food noise around us, and that is all the causing the metabolic issues. Second thing, the stress management should be come from the mind, as you told. So we had a research in the type 2 diabetes in Kanpur while I was doing endocrinology. That time my mentor and I has done the research about how meditation would be impactful on the glycemic control, and we have published to the ISPID and many type 1 diabetes guideline that meditation has a key role. It won't make your sugar 300 to 200, but you have a mindful eating, you have a subtle mood corrections, so that corrections can be made. And third would be your physical activity. If you are doing physical activity, then you are running adrenaline, cortisol, and growth hormone in sustainable manner. So your body is going to into proper repair mechanism. So I think this all the four parameter, and particularly yes, sleep, because I was thinking in that way कि भगवान ने हमें ऐसा दिया हुआ है तत्व कि जिसमें ना तो हम रिप्रोडक्शन कर पा रहे हैं, ना हम खाना खा रहे हैं, ना तो कुछ भी काम कर रहे हैं, कोई आके अटैक करेगा तो भी इट वुड बी वेरी डेंजरस फॉर अस. सो सारे एनिमल्स को वो तत्व दिया है, दैट इज अ स्लीप, एंड दैट इज मिसिंग राइट नाउ. सो व्हेन वी वर टॉकिंग अबाउट आवर ग्रैंडमदर एंड एंसेस्टर, they if they would be here, then वो हमें डांटते कि इतनी लेट ना सो. So all these issues were creating the psychosocial issue. I think with the GLP-1 analogs, SGLT2 inhibitor, with the anti-hypertension medication or like cardiac medication, if we give focus on these particular things, then half of our populations could save their money for not going to the doctors, and all the kind of the metabolic syndromes and the metabolic disease can be avoidable.
Thank you. That makes sense, and this is something that we can easily share with our patients and, of course, with ourselves as well. These three primary needs of every animal: sustenance, that is food, and sleep, and sex. These are actually the three basic needs for any animal species to survive and to thrive. And you can tell people that sleep is as important as any other aspect. And this brings us to another M, which when we speak of mind management or mind modulation, you can also talk about meditation to your patients. So we are nearing the end of our discussion. And what we see is that the more we speak with each other, that's how we began, the wider the concept of metabolic health becomes. And we struggle actually to put everything into one sentence or one paragraph. What is the definition of metabolic health? Only if you have a definition, only then you can think of targets. And if you think of targets, only then will you be able to decide your techniques. But we also realize the good thing that it's all interlinked with each other. You catch hold of one thing and you are able to move to the next. This I realized a few years ago, after many years of mistakes. In general, in endocrinology, in nephrology, in cardiology, we are all trained in linear thinking. That is Newtonian physics. So, for example, the cardiologist would feel that, yes, I put in a stent, now the blood flow has started, now everything will be jingalala. It is not always as simple as that. There are so many other aspects which are influencing the health of the stent. The nephrologist will think, yeah, I got this nomogram, so if I give SGLT2 inhibitor, the EGFR will go down by this much percent over 1 year, but over 10 years it will remain sustained. Every patient doesn't follow that nomogram. In endocrinology, we will feel, yes, you give 10 units of insulin, the glucose comes down by 50. It does not happen like that at all. This is Newtonian physics. There is a shortcoming to that. There is a limitation. So then you understand the concept of Einsteinian physics or quantum physics, which says energy is equal to mass, c square, and that c can be anything. So suddenly you have mass in front of you, like you have obesity, it can vanish and it can become energy. But every person will behave differently. So that is why someone may accept insulin, another may respond differently to it. Someone may come in with CKD, stage 4 and 5, and may remain stable for 8 to 10 years at stage 4. Another one will have rapidly progressive glomerulonephritis and will worsen in front of your eyes. Within a few weeks, patient will go into CKD stage 5. and Dr. Nirmal will know. You can do all the tests, and you will feel, yes, this person will not get heart failure, and that very person will land up with you the next night in casualty. So this is Einsteinian physics or quantum physics. So many things influencing metabolic health, so many things influencing our targets and techniques. So let us try to summarize all this, and perhaps we'll start with Dr. Nirmal. Sir, from a cardiac perspective, any three or four do's and don'ts that you would like to share with our audience, all physicians from across the country? So anything
So,
that can keep our heart healthy.
sir, for me, I focus on three S. That is sleep, screen, and stress. As we have already discussed, stress has a majority things to do with your metabolic profile. So I advise 10 minutes of meditation daily in the morning. Apart from them, at least 20 minutes of walk to move around whatever speed or what at whatever level you can do just simple walking. You should do that. You should not overexert, but at least you should walk at least 20 minutes a day. Third one, very important thing, what I advise them, please don't use screen, any tablets or phones at least 30 minutes before your planned sleep time. If you're sleeping at 10, you should stop using your phone by 9:30. Reason being, your brain needs to be calmed down before you actually it goes into sleep. Right. The moment you start using the phone, you nowadays people are just scrolling the reels like 1 hour, 2 hours in that way. Every single minute, every single second, you are jumping from one topic to a different topic. That stimulates your brain. That gives more cortical spikes, and ultimately, high cortisol level leads to inflammation at endothelial level. It increases your blood pressure, it increases your heart rate, and all these parameters has a direct correlation with any cardiovascular health. So these they are the three basic things which I will advise to each of my patient, whether they are patient of heart failure, whether they are patient of coronary artery disease, or they are just a simple patient with the hypertension and dyslipidemia. So these three things I'll advise each and every patient, regardless of their age, regardless of their other any risk factors, and it has to be followed by everyone, like all of us who are professionals, who have working tirelessly throughout day and night. We are also part of this system, so we'll have to apply this simple things in our routine as well. Then it will have a long term benefits as far as our health is concerned.
Thank you. So very crisp and clear-cut take-homes for us. Reduce screen time, ensure good sleep, and also smart movement, exercise as well. So smart movement. Dr. Umesh, anything you would like to add from a renal perspective? What else can we do to take care of our kidneys?
I'll just say three things. Two don'ts, like do not take NSAIDs avoid as much you can. Second, herbal always caution, because we see lots of kidney and liver failures or at least worsening of CKD. And third thing I will say, early renal protection, that is a key for any metabolic syndrome patient, either only diabetic or diabetes with hypertension, or diabetes with hypertension with coronary artery disease. Early renal protection with the newer molecules is the key.
Thank you. And Dr. Manoj, perhaps you'd like to summarize. We want to take care of the heart and the kidneys, but what about the rest of the body? And
Yeah.
the challenge to explain to our patients is they know what the heart is, that weighs around 250 grams. They also know what the kidneys are, 200 grams apiece. But the beta cell, the total weight is just 0.8 gram in a lean adult and just 1.2 gram in an obese adult. So for that 1 gram of beta cell, how do you make the patient conceptualize it? How do you make them understand that they need to take care of it?
So, yes. So, when, sir, I was doing my endocrinology, that time Dr. Anurag Bajpai always used to tell us that, do you know what is the content or what is the ml of your hormone of your total body? So, we were giving the like answer like that it would be 1 liter, 500 ml, like that much. But actually, the hormone content of your body would be the similar to the 5 ml. So 5 ml hormones is maintaining your all the bodies, and this is not just about the 5 ml. This is not just about your insulin resistance, weight gain, kidney or cardiac health, but it is about your background, how you are doing in your background. So I think, as Dr. Nirmal has said, that 3S should be main focus: sleep, and the stress and the screen. Now nowadays this is the becoming the paradox, and after 1975 we have seen, now we are talking about the metabolic health, that previously we have not need of talking like this. So I think as an endocrinologist or as a physician, we just don't have to focus on the glucose, but we have to restore that metabolism. We don't just have to lose their weight, but we have to do the infrastructure of their metabolic health. If we are doing for our patient, then I think our all work has been completed in the true physician's manner, because our job is not just give a pills. We have to talk about the preventions. So I think, and for that panel, we have started one work in the Gujarat. So we have given the name Dr. Dal Rotika Sawal Hai. This is for the doctors only. So might be Dr. Umesh is aware about that session. So I think as a doctor, we have to change our lifestyle. That is the main thing, because the circadian rhythm and all things matter a lot, and that is, otherwise we need to take SGLT2 inhibitor later on. So I think prevention and pills should work together.
That is an awesome idea and very good movement from the Gujarat doctors. Dr. Nirmal, there is a question for you from Dr. Sudhanshu Budikoti. He is a cardiologist practicing at Mohali in Punjab. And he says when we go to Gujarat, the food is so tasty. It is full of sweet and it is full of saturated fat. So the question is, what is your favorite Gujarati dish? And what do you tell your patients about that?
Sir, my this question is expected. See, I personally like gulab jamun and jalebi, but I usually try to avoid that. I think majority of us would be agreed with this. These two dishes are very common whenever we go to any places, any functions, and all that. My personal advice to my patient would always be, if you want to eat, you eat it, but you have that gut to burn it out. If you are eating something today, go to walk. If you are having something at restaurant, then walk 40 minutes after that. I myself do gym 1 hour, almost 1 hour to 1 hour 15 minutes every single day in the morning. So I'll give them my example only. I have this watch which shows the amount number of steps I'm walking. So I'll show them this pink circle, that it is a target of 10,000 steps. Until and unless I'll finish it off, I won't sleep. So even they will understand that if doctor is doing, who is working around 12 to 14 hours, he has to take the emergency call. He wakes up at night to take the calls. He goes through the procedure and still is doing the gym every day in the morning, and he's completing the 10,000 target steps. So why I cannot do at least 5,000 steps? This is a simple message I convey to all my patients. You eat whatever you want to eat, but you have that courage to burn it out right after having it. So this is a simple message I just pass on to my patient who are very much foodie, like in special Gujarati patients.
So we practice what we preach. Dr. Umesh, what about Gujarati cuisine and electrolytes? So this question comes to you from Dr. Saurabh Sharma, who is a nephrologist at Safdarjung Hospital in New Delhi. And he says we speak about hygiene in nephrology, whether it is dialysis hygiene, whether it is electrolyte hygiene. So specifically from a Gujarat cuisine perspective, what are the things that we should know so that we can manage health in our patients with kidney disease?
Majority of times, the most important is the potassium management, which becomes challenging. I had already discussed about the protein part, so that is not a major challenge. But yes, because majority of our kidney patients are particularly fond of fruits or seasonal fruits, which are in, and fruits and dry fruits, and particularly diabetic CKD is a combination where the potassium excretion is very less, and they are very prone to hyperkalemia. So I always want to continue them on protective therapy, but potassium becomes a villain. So definitely, dietary restriction is very important. And there comes the high potassium containing foods. Of course, fruits are the main thing. Then aloo, potato is a very common food in Gujarat and very frequently used. And it is, I think, problematic for all diabetics as well as for kidney patients as well. Like my dialysis center in Selby Hospital. Me and Dr. Manoj are both attached with Selby Hospital. So there, our patient always used to eat aloo paratha during dialysis session. So at one time we are removing the potassium, and on the another end they are eating the same. So yes, I think the potato is the main challenge, because different type of chips, fries, or namkins are the favorite food patients eat during the dialysis. So at the one end, I'm giving them 5 to 6 antihypertensive, because the CKD, advanced CKD, has such a severe resistant hypertension. Uh, our few of dialysis patients are taking all the available antihypertensives still, and we are doing even 4 times a week dialysis, optimizing dry weight, but still the resistant hypertension is a very big problem.
Correct.
So again, papad and napkins are also very common in Gujarat. So the diet restriction, particularly salt restriction, potassium restrictions, these two are very challenging in our Gujarati patients, because they will not leave actually namkeen and these things.
Hmm.
And
So we need to counsel them. And when we use the word metabolic phenotype, we are actually putting all the blame on genetics, on metabolism. But the moment we start using the phrase nutri-metabolic phenotype, then it means we are taking the responsibility on ourselves. That means I should optimize my vitamin D and calcium. I should increase my protein intake, and I should also reduce unnecessary sodium and potassium intake. Dr. Manoj, one question from Dr. Mukut Roy. He's an endocrinologist in Tripura. He says many times we recommend fermented bamboo shoots to our patients. So that increases satiation and satiety. It's also a very filling meal. And apart from the satiation and satiety, it increases the probiotic load. It improves gut microbiome diversity, and it improves metabolic health. So, fermented bamboo shoots are used in the Northeast. What about Gujarati cuisine? What are the commonly used fermented foods that we can advise to our patients?
Yeah, so this is, I think, very nice question. That fermented food, what is the concept of the fermented food? So, like every day in our OPD, when somebody is taking or starting protein, like properly Gujarati person, because they are the like more carbohydrate eaters. If they started taking protein, that time they started developing a complaint like they have bloating, dyspepsia, and everything. So I think all the doctor has been seen this kind of the complaint. But the protein is important, but art of protein is also important. And how does it come from? Because gut microbiota, as you were talking about. So in the Ayurveda, it was a very well said that every problem is coming from your gut. So now, because they were talking about the pitta and the pitta prakriti and gas prakriti. So similar way, as an endocrinologist, gastrologist, and everybody is now talking about the gut microbiota. So this fermented food has been designed in that way that can goes to our gut microbiota, let's say highs, and it is kind of the prebiotic and probiotic, and that increase the absorptions and the increase the friendly environment for the food absorptions. So I think whatever he's using in the eastern part, that we are using in the western part also, that is a dokla. So everybody loves dokla. So it is it is the logic behind the dokla would be that Gujarati is a less carbohydrate eaters, so give something a protein in contents of the dokla, and they get fermented into it, and next day we can make it. So it is very healthy if it is not added with the talka of sugar and oil talka, then it would be very healthy. And with that, many Gujarati people used to eat uh, uh, the uh, the curry and mungphali's chutney. So that is also giving the medium chain fatty acid. So whole concept of each and every culture has been designed in that way that can nourish the human population of that particular region. So I think in the eastern there is a different culture. In the western, the dokla has been designed not to just satiate our taste, but to design in that way that can goes to your gut, say hello, and can make a friendly environment to the gut microbiota, and in the background they can give a protein.
Thank you. This is really useful information, and this is something that we can follow throughout the country. So I'd like to thank all our speakers today, Dr. Manoj, Dr. Umesh, and Dr. Nirmal. Together, we have just begun exploring the wide expanse of metabolic health. But we have learned a lot about our targets, we've learned about our techniques, and I guess we've all enriched ourselves in this journey. We are humsafars or traveling companions in this journey towards metabolic health, and that is what 4D is all about: detailed discussion and dialogue related to Indian diabetes. Thanks once again to our experts, to the three musketeers, for having helped us move further in this journey towards better health. Thank you, everybody, and Jai Hind.
Okay.
Thank you, everyone. Thank you, sir. Yes.